Hello and welcome to our third broadcast of Food for Thought, our mental health podcast from Virgil Stucker and Associates. I'm Virgil Stucker. Good morning to you all. Today we have the great pleasure of speaking with Scott Leshin, who is the founder and president of SJ Health Insurance Advocates. They are a health insurance claim management and advocacy firm located in New Jersey, but they're serving families from all over the country. And seems like every time I talk with Scott lately, the number of people that he has on his team increases. And I heard that since last week, I guess it increased from 40 to 42 people. So it's amazing. And we'll hear a little bit more about that story in just a moment. You know, as viewers who are on this podcast know, and I know that we have, people from across the country, families. I think we even have someone listening in from Israel, families and providers. I mean, we all know that medical insurance companies typically try not to provide any kind of coverage beyond perhaps crisis coverage in the hospital. Scott and his team are helping families try to secure medical insurance reimbursement for mental health and substance abuse services beyond the crisis, because obviously there is care and treatment that is still needed. So he's helping families reach into residential care, other specialty care, community-based care, and basically trying to help insurance companies comply with the federal mandates for parity. That is, mental illness should be treated equally with physical illness. Our conversation also today with Scott is timely because there are some major court cases that are underway just on the 4th of March, just a few days ago. Most of the viewers probably have heard now about the federal judge in California who has decided that UBH, United Behavioral Health, has been discriminating in its policies and practices in regards to providing access to mental health care and substance abuse care for its members. And we're going to talk about that case because it has a national impact. It's actually huge, but we'll get into that in our conversation. So Scott, anyway, pause a moment, say welcome. You're in New Jersey.
Good to be here. Thank you.
Oh, goodness. Thank you. Thank you. Before we continue into the podcast, I do want to thank Stephanie McMahon, who is producing these podcasts. She's in the background supporting how this is smoothly running, and also to point out on the right-hand side of your screen is a chat bubble. So while Scott and I are having a conversation, if you have questions that you'd like to submit, please click on that bubble and submit your question, and Stephanie will feed that to me so that we can bring it up during the conversation or perhaps at the end of it. And also at the end of the conversation, you'll have Scott's email so that you can continue to correspond with him. So Scott, I know that you come into this work for very personal reasons. I know that you have a son, Sam, whom you've been supporting, a young man with cerebral palsy. And as a parent, you've had to go through all of the struggles that parents sometimes go through to try and get medical insurance coverage. And I know that, that's probably an ongoing daily struggle. You learned a lot in that process. And I know while you were learning, you were having a very busy career on Wall Street. You've been working with Morgan Stanley, Goldman Sachs, after getting your bachelor's degrees from Syracuse and also a master's degree from NYU Stern Business School. So you left that Wall Street job and said, I want to use some of what I've learned to help some of the other families who need help like you have. And so, certainly congratulate you and honor you for doing that, Scott. Now with you and your 42 employees, I know that you're reaching out to help families across the country gain access to treatment that is just beyond the crisis, and treatment that, if they can get access to it, will probably help prevent crises. So Scott, thank you for being with us today.
My pleasure. Thank you.
I think, when we have a conversation like this, we talk about sort of three major talking points. The viewers who are seeing us visually can see those talking points on the screen. Let me speak those for those who may be listening to us without seeing us. We want to frame the issue a bit more. Understand, why is it health insurance companies have been so reluctant to cover residential treatment or treatment just beyond the crisis, and try to understand how families can be smart in this process of trying to grapple with and obtain coverage. What are the pitfalls they should avoid, and how can they get the most out of their insurance company? And then, as I suggested in the beginning, we want also to discuss the court case, and especially the one that was decided this last Monday, and another one that I know, Scott, you're involved with that is coming up. So, Scott, can you help us first with sort of, why the heck don't medical insurance companies cover treatment that is obviously so important and might prevent future crises? What's up? Why are they not doing it?
Sure. And throughout all of these, throughout all this conversation, it boils down to follow the money. And I'm sure I'm not saying anything that no one already knows, but at the end of the day, the health insurance company is in the business to collect premiums and not pay out claims. Since the Mental Health Parity Act was passed many years ago, and then coupled with the Affordable Care Act, which mental health falls under as far as an essential benefit, insurance companies have been very hard pressed to reimburse for claims for not only acute inpatient, but residential, partial hospitalization, intensive outpatient, wilderness, et cetera. And it's just a bottom line decision. They are throwing up roadblocks in any which way they can to make it very, very difficult for families and providers to secure insurance reimbursement. And this could be anything from using clinical care criteria, which the UBH case will touch upon, that is completely irrelevant for the level of care being rendered. Things such as you have to have a case manager assigned to your case before admission of treatment, or just making the authorization process very cumbersome, whereby authorization has to be specific to residential. Authorization has to be granted within the first 24 to 48 hours of admission, and every 3, 5, 7 days thereafter. So it certainly becomes a big burden on the provider who's trying to render care, as well as the family who's trying to not only have their loved one receive care, but also get financial financial reimbursement for such care. So all this process is designed in such a way to make it very difficult and very challenging, simply to save money.
To save money in the short term, I guess that's what I'm
hearing. Save money in the short term. That's right.
It, I guess for a while I was realizing that, when we have a medical insurance coverage, it seemed like there were several different carriers, and it seemed like the average that you might be under one carrier was like a year and a half, 2 years. So then you switch to another one. Were these companies just sort of, kicking the can down the road, so to speak, and not wanting to, understand or acknowledge that actually investing in more care up front might save them money over the long term? Did they just want to go for the short term because they didn't know if they were going to have the long term?
Sure. Well, look, obviously I come at this from a very cynical perspective, just based on what I do all day, and as you mentioned, personally as well. So, when I'm looking at this and saying to myself, well, why are they denying residential when, God forbid, if they don't offer residential for a 30-day stay and the patient then goes out and overdoses or hurts themselves, is that going to become more expensive? And the answer is it's not. And I believe that because the insurance companies have statisticians and attorneys and, significant amount of data to say, okay, it's worth denying all these cases because odds of having to pay out a larger claim down the line are very, very low. Similar to, when you deny a claim and go through the appeals process, families can litigate thereafter, but how many of those families are really going to hire an attorney to go through that extensive process that could be very costly for them with an unknown reimbursement, as well as drag their loved one through having to testify and go through court? They understand that odds of that happening are very, very low. So it's a gamble that they take, but so far it has paid off because the insurance companies are recording record profits year over year, even in the face of the Affordable Care Act, where they complain that they weren't able to sustain their business. That's a fallacy. They're making billions.
So I guess maybe I'm coming at this from a bit of a naive perspective. I'd like to think that the people who are involved in all of this are more mission focused than money focused. But what I'm hearing from you is that in your experience, you're finding that it's really all about the money.
All about the money. Absolutely.
Okay.
And there's been cases, not only the ones that we're going to talk about later, but there was one about a year ago that was on 60 Minutes with an Aetna doctor who said he's never looked at any case notes. He relied on the nurses to tell him whether they should deny, but he was signing off as if he read it. The list goes on and on and on with what these insurance companies do.
I think I remember seeing that program. I think he was called Dr. Denial or something like that.
There was also Dr. Denial, which was a California-based, I think it was Timothy Johnson was his name, if I recall. Apologies if there's another Timothy Johnson out there that I just threw you in this, but there was another doctor called Dr. Denial on 60 Minutes. And the other thing is if I don't know if I'm getting too far ahead of myself, but about the appeals process is the supposed IUROs, independent review organizations, are also able to work for the insurance company on first and second level appeals as well. So there's a complete conflict of interest there when you're supposed to be independent working for the state insurance commissioner or under ERISA, yet the guy down the hall can work for United Healthcare and Aetna. Well, where's there more money coming from? It's obviously the insurance companies.
Oh, so Scott, amidst all of this, I'm looking at the background behind you, and it's sort of reminding me that I see you sort of as this warrior trying to help families break through the barriers that that exist between them and their family member and getting medical insurance. So you're cracking open the barrier. And I thank you for the many families that I've referred to you for the help you've provided them in navigating this very challenging situation. So I'm entering this conversation feeling more hopeful than not. Let's move a little bit toward that hope. As far as how there can be success. What kind of knowledge can you share with, especially the families perhaps who are listening, as far as what they can do right now to be successful in trying to get coverage, especially beyond hospital, maybe residential coverage, specialty coverage, other treatments that could be accessible in the community? What kind of advice would you have for them if they are, they call me daily looking for support? How do I get medical insurance coverage? What can I do to sort of enter this battle? What's the first thing that they should do? How should they proceed?
So certainly there's two themes. One is don't give up, because the squeaky wheel does get the oil. So those families that do fight and continue to fight and push, their odds of success increase significantly. The insurance company is hoping that all these roadblocks will make you give up. And then also you have to be an educated consumer. The Affordable Care Act made the insurance landscape in the United States such that most policies read the same. You've heard the essential benefits. So an Aetna plan, and I often get asked, is Aetna better than United? Is better than Cigna? Is better than Blue Cross? They're all the same. And to me, my answer is they're all terrible. What it boils down to between different companies is customer service, which is obviously comical when it comes to insurance companies, and costs, premiums, deductibles, co-insurance, out-of-pocket max. But looking out across the landscape, most insurance policies, there are very, very few exceptions at this point, do have to cover residential, partial hospitalization, intensive outpatient, et cetera. Just knowing the policy, knowing what's in the plan, knowing if your policy is fully funded or self-funded, and I'll come back to that in a few, prior to engaging in treatment is the way to go. Now, I know this is a challenge because you're dealing with a child or yourself or a loved one, a spouse, who is going through an illness that that obviously is your primary focus. With that said, you should call people like Virgil or myself or the facility in which you're going to and say, all right, what do I need to know before admission to be successful with the insurance process? What gives you a very good overview of what your policy will cover is called a summary plan description or a certificate of coverage. So this is a 100, 200-page book that everybody gets once a year. Most people, throw it out because who's going to sit there and read that? But that book is going to detail what your coverage is for various levels of care, what your appeal rights are, who regulates your policy. So I do recommend then when you are dealing with a loved one that is going through an illness, that you save that book and refer to it as you go through the process, because educating yourself and being that smart consumer is going to get you where you need to be. And lastly, don't give up. So there are all members. I'm going to somewhat talk about the authorization process as it relates to residential treatment and the appeals process. So for the most part, and again, there are going to be few exceptions to this, so I'm painting everybody with the same brush here, but just know that I'm trying to make this all work for the larger audience. Residential treatment requires authorization within the first 24 to 48 hours of admission and every 3, 5, 7 days thereafter. So it is very important that when you are looking to admit to a residential treatment center, that is the provider going to be doing this? If they're in network, they have to. If they're out of network, they do not. And if they are an out-of-network provider, do they have a resource? Do they have an SJ, or do they have somebody in-house that is going to work for you to secure insurance reimbursement? If they don't have any relationships with anybody, be it in-house or external, then it's important to work with your consultant, Virgil, or any others to find out what your options are, because somebody has to make those calls. Short of making those calls, the family will be denied administratively, which can be a dead end, because if you fail to make that call, they can put up a wall and say, sorry, you're out of luck. So it is important, again, to partner with somebody to engage in that and stay on top of it. And just know that your next authorization is going to be done in 7 days from now, that the team is calling back in on day 8 to get authorization again, and keep doing that concurrent review throughout the duration of the process. At some point, authorization will inevitably be denied as the individual progresses through treatment and, God willing, starts to recover. The care criteria, and we'll go back to this when we discuss the United case later on, but the care criteria for RTC is very stringent. So as they start to do better and they're less of a risk to themselves or others, or stable on medications, the insurance company is going to want to step down to a lower level of care. You can accept that and step down. The facility can accept it and step down, or you can do an appeal. So an appeal, you're allowed, the provider has appeal rights and the member has appeal rights. On the provider side, a provider can do what's called a peer-to-peer appeal, whereby a clinician from the treating provider or a third party can engage the care manager at the insurance company and demonstrate on a live call as to why it's medically necessary. If the insurance company then overturns their decision, then authorization will continue. If they continue to deny, then I recommend that the family engage their member appeal rights. There's two ways to go with this. You either have a self-funded policy, and self-funded policies mean you're getting insurance through an employer. It's typically a large employer, and ultimately the employer is the one who's paying your health care costs. And then, or it could be a fully funded policy whereby the insurance company is paying your health care costs. And I'm going to explain this a little bit more granular in a second, where the insurance company is paying the costs, and it's then regulated under the state in which the plan was written. So going back to fully self-funded. So what this means is a family, and I'll just use my former employer, Goldman. So Goldman Sachs was self-funded. They had 35,000 employees. They can spread out their risk amongst a large number of employees, which is why they're able to do a self-funded policy. And it's cheaper for them up front. We used United Healthcare as the administrator. So what happens is I would file a claim to United Healthcare. United Healthcare would reimburse me. And then United Healthcare would send a bill to Goldman once a month and say, we just paid out $5 million worth of claims for your employees. Goldman Sachs would cut a check for $5 million. So United Healthcare makes an administrative fee, but the employer is actually paying for the healthcare costs. There's benefits to that, and there's disadvantages to that. The benefit is because the employer is paying the healthcare costs, if you choose to, you can go to the employer and say, I am being denied for X, Y, and Z reasons. I feel that this is not appropriate. I would like you, the employer, to step in and advocate on my behalf. And the employer, if willing, can make a call to United Healthcare and say the intent of the policy was to cover this type of treatment. Because we're ultimately paying for it, we want you to go ahead and authorize treatment. The other side of the coin can also happen, where they say there's nothing we can do, or there's nothing that we want to do, taking a cynical approach, and you have to follow United Healthcare's policies. If they, for example, are the administrator. Self-funded policies can also write in more benefits or take away certain benefits. It's getting harder and harder for them to take away certain benefits under the Affordable Care Act. But there's certain things they can or cannot write in that can make this process either easy or hard. I found that for the most part, self-funded plans are good to work with. Your employer usually cares. Obviously, the family has to decide if they want to let their personal lives into work and share with the HR person at the employer, what's going on in their family. And those policies, are regulated under ERISA law through the U.S. Department of Labor, and that's who ultimately you appeal to. On the fully funded side, it's like picking off an over-the-counter medication. You can call Oxford and they say, okay, United Healthcare, here's our platinum, bronze, gold policy. Platinum costs this, gold is this, bronze is the lower of the two. This is what we're going to cover. They're all going to cover the same thing. It's just a matter of cost. And take it or leave it. And if you buy it, that's your plan. There is no, other than calling the insurance company, there's no other place you can turn to until it gets to the external appeals process. The external appeals process under a fully funded policy is regulated by the state in which the plan was written. So you are going to be looking to them to help you through that appeals process. So going back to appeals, after you're denied, you have, as a member, most plans have 3 levels of appeal, 2 with the insurance company and 1 going to the plan regulator. We found that most of the first and second level appeals are denied because it's the insurance company. It's supposed to be a separate group within the insurance company, but it nevertheless is the same insurance company that's going to render a decision. So short of presenting them with new facts or findings that might have been not introduced on your first level appeal, level 1 and level 2 is typically going to be denied. You then can go to the plan regulator. In New Jersey, it's Department of Banking and Insurance, New York, Department of Financial Services, California, Managed Care. Every state has to have an insurance commissioner, and you're filing an application to the state and saying, I was denied for X, Y, and Z reasons. Here's why my treatment should be authorized. You put together a comprehensive case, as well as coupled with medical records. That goes over to the state. The state then turns that over to a contracted IRO, independent review organization, and whoever they contract with is going to review the case and make a binding decision on the insurance carrier, meaning if the IRO finds in your favor, the insurance company has to pay the claim. If they deny and uphold the insurance company's decision, well, then you as the member have the right to take legal action.
Okay, let me, wow.
That might have been a lot, yeah.
You've learned a lot. I mean, okay, up on the front end, I'm hearing how when families are approaching the need for care beyond the hospital, like residential care or care in the community that might be funded, there's obviously a need for an advocate or a partner. And sometimes the program may provide that kind of service. And in some cases, you're supporting programs with that kind of services. And other times, families reach out directly to you because, I mean, obviously there's a lot to navigate. I'm hearing some concepts in network, out of network. Maybe we can get back to a little bit of those. Sometimes I hear about single case agreements that can be made. Before going, maybe, while we're thinking about concepts and processes, I'm wondering if there might be almost like a case or a situation without, of course, divulging anything, personal or identifying. Let's say we had, someone with a serious mental health diagnosis and they were coming out of the hospital, going into residential and maybe further along the continuum. Can you give us a sense of what some of this actually looks like at the family and at the individual level? even looking at maybe some of the diagnoses, the kind of care that you've been able to secure. Like how long, are you seeing possibilities of getting residential care coverage 2-3 months, or what are some of the situations you've seen that we can maybe look for with some hope?
Sure. So let's act as if we're the patient, So I'm the patient for the purposes of this. I just came out of a hospital. I'm now looking at a residential treatment program for continued treatment. So depending on the type of policy I have, and it could be an HMO, which is in-network only, and I'll define in-network and out-of-network in a moment, but an HMO and an EPO have in-network benefits only, and a PPO and a POS allow you to go both in and out of network. What network means is the facility contracted with the insurance company? Do they have a contract that we're going to bill RTC at a rate of $500 a day? This is what you, Aetna, pay me for services. We still have to go through the authorization process, but the financial impact to the family is going to be significantly lower if authorized than it would be out-of-network. An out-of-network provider does not have a relationship with the insurance company. They can charge whatever it is that they want to charge. Insurance can still play a part in reimbursing so long as the patient has out-of-network benefits, but the patient can have a significant amount of financial risk because let's say the out-of-network provider charges $500 and insurance reimburses $200. The provider can seek reimbursement for $300 a day for the duration of treatment versus, again, when you're in-network, the bill rate is what you're going to get back. You're only responsible for deductibles and co-insurance. So it's important to look at that and say, all right, are we looking at, and I often get calls from families that say, which treatment center is better? And my response is always, I'm not a clinician, so clinical aside, that's for you, Virgil, and the clinical care team to make those decisions. But this is where you're going to have the best chance for reimbursement success. And again, in-network is going to be easier than out-of-network. Single case agreements you touched on. Single case agreement basically makes an out-of-network provider look in-network for a specific period of time for a specific facility. So let's say I need a residential treatment center. There are no residential treatment centers within 50 or 100 miles of my house or where I live. I can then call the insurance company and say, I need to, this residential treatment center, which I'm looking at, is 200 miles away, but because you don't offer an in-network solution in my area, I want a single case agreement. What happens there is there's a negotiation between the provider and the insurance company to come up with a price and say, all right, we're willing to accept $500 a day in reimbursement from you, Aetna, for a certain period of time. The utilization review process or authorization process still has to take place. Usually, though, there's a longer upfront period of time, and it's a little bit easier going through that authorization process under a single case agreement. You then asked me, how long can a family expect to be authorized in residential? We all have outliers to this. We have, in my work, I might be able to get 7 days. I might be able to get 7 months. But, you realistically, you're talking 30, 35, maybe 40 days. Short of anything happening to the patient while in treatment. If, God forbid, they don't take their medications or they have a suicide attempt or something gets uncovered while in treatment, you're looking at, 30 to 45 days, we'll say. And a lot of these treatment programs are significantly longer because you're not cured from a mental health illness or an addiction within 30 to 45 days. And unfortunately, that's, the argument, and that's where the United case was going. But that's just the reality at this point, is that's what you're looking to get.
Okay. So here's a scenario. Let's say we have a young man, 24, and he's had 8 hospitalizations and is diagnosed with schizoaffective disorder. And basically, he's been going to the hospital, back home, or to the hospital, maybe to an apartment, and maybe trying to get along with an outpatient psychiatrist, psychologist, whatever, but just back and forth, and it's just not working. So family, professionals involved say, okay, let's try the full continuum. Let's see if we can get this guy into residential treatment, maybe then into sort of a community option, whether it's called IOP or, something like that, and maybe down the road into something like a PACT program, assertive community treatment. That obviously in a case like this is going to give a better outcome, at least according to my experience. So families trying to get the optimal outcome while also getting maximization of insurance coverage for this. So I'm hearing you say on the front end, are we saying we can reasonably always hope for maybe 30 to 45 days, maybe push it longer than that. And once the person gets into the community, things like PACT program or other community-based care, is any of that ever covered by medical insurance?
Sure. So, there are clinical policy guidelines that are published. You can find them on the internet for United Healthcare, Cigna, Aetna, and it details what the patient has to meet in order to demonstrate medical necessity. From a residential treatment perspective, they're looking to see if you're, a danger to self or others. Are you failing in activities of daily living? They used to say, and they're not allowed to say, have you tried lower levels of care? That's in breach of parity, and that's been vetted through the courts. But, are you on medications? Do you have a biologically based mental health illness? So, I often get calls where there's a 24-year-old that smokes marijuana and has some beers on the weekend and anxiety. Well, that's not going to get you residential treatment level of care. Schizoaffective disorder with visual and auditory hallucinations coupled with an opiate addiction, that more or less will get you authorized for a certain period of time for residential care. So, the cases that get approved are very drastic cases. The insurance company is not interested in helping an individual before they get to that point, meaning, am I better off helping somebody with some anxiety and a marijuana addiction before they turn to major depression and an opiate addiction? The insurance company doesn't care. So, it's what's present at this current time, not what happened 3 years ago, but more or less what is going on within the few days of admission, and they need to see that very, very high level of need. As far as stepping down in lower levels of care, let's just say it's 30 to 45 days for RTC, and let's just say 30 days for RTC. Then partial hospitalization, which is a day program. Hopefully that's 2, 3, 4 weeks, and then intensive outpatient could be 40 some odd sessions of IOP. So that's when we're discussing cases and we're looking at when a family calls me, this is what you can expect. Obviously, so long as you meet what we discuss as medical necessity, but that's more or less where these families are going to fall.
Mm-hmm. Well, thank you. So that's some hope, and we're moving perhaps in, as we get into the court cases in a moment, I think we might see some additional cracks toward maybe moving toward even greater hope. But two questions, and these are sort of technical questions, maybe not, but anyway, specific questions. So I mentioned before a 24-year-old. What about that magic age of 26? Just a specific question. Sure. What should a family be doing if they have someone who is somewhat disabled by mental illness and or addiction at the age of 26 and they're under the family policy? What should they be on the phone doing?
They should look to continue coverage under the age of 26. So the Affordable Care Act said that so long as you have an illness or injury, and of which mental health qualifies, that you can stay on your parents' plan past the age of 26. And I did this for my son who's 12. I just did it because, it's one less thing that I could check off the box. But every insurance company has a form that you have to fill out and demonstrate need. And it's different insurance companies call it something else, but it's for United Healthcare, it's past the limiting age of 26 form. So as long as you're talking to your insurance company and saying, I have a young adult, they're going to be turning 26. They are suffering from schizoaffective disorder and a whole host of other ailments. I need to keep them on my policy. They will send you the form. They'll direct you on the web. You'll complete that form. You'll couple it with medical information, and the insurance company will then keep that individual on your policy past age 26.
Okay. Does having guardianship have anything to do with keeping the person on the policy, or is that incidental?
Having guardianship. No, because at age 18 they're their own individual regardless. So that doesn't necessarily that. Let me walk that back. Having guardianship will augment the request for why that individual needs to stay on the policy past age 26. Because if you are awarded guardianship, then obviously the courts found that this child is in need. So that'll certainly help strengthen your case to keep you on past age 26.
So thank you. One other question before we perhaps go to the court case. So I'm not hearing you say, hey, Virgil, there is this really, really great insurance company that's doing everything that is needed. Is there a best company or a better set of companies that families should be looking at? And which one should we be avoiding? Can we put it that way? Do you want to go on record with any of those recommendations?
Yeah, that was my hesitation. Yeah, look, I think there's probably my face on a dartboard at some of these insurance carriers. They know me, they don't like me, and the feeling's mutual. There's no one good insurance company. It never has. I don't imagine ever will. But there certainly are those that are just god awful and terrible. And I'll single them out right now. And if they were in my office, I would say the New Directions. You're one of the largest behavioral health carve-outs, and you have a large presence in Florida, and you are doing an absolute horrific job. They're doing a good job for their shareholders and their owners, but they're not doing a good job for the community. And I can really just give examples where a case is called in, and at 4:30 on a Friday, the insurance company calls back and says, okay, you have a half hour to do a peer-to-peer call. Well, how is that going to be possible? How am I going to get a doctor, pull them out of treatment to get on the phone with you within 30 minutes? That's not reasonable. Or they call back on a Saturday and say you have until Sunday to get me the clinical information. These are the tactics that these insurance companies take. New Directions right now we're facing is by far the worst insurance company, and they're going to be facing some big issues shortly.
Okay. I think we need to start moving to these court cases because I see that we're running out of some time. So this Monday, March 4th, I'd gotten an email from one of the attorneys in the California case before federal court, Judge Spiro presiding. Got an email from Miriam Bendat that had alerted me to the findings, which I think for the class, for families and others needing access to mental health care beyond mental health and or substance abuse care beyond just the typical crisis care, this is major. It appears as though the federal court is now saying that the very narrow definition of medical necessity is just not going to work anymore. And I realize that this isn't going to change things overnight. And the New York Times article, I think it was this morning, also indicates that it's going to be 2 months before the judge does his final ruling. And then I've heard from one of the plaintiffs for the class that said that, and by the way, I want to credit Eric Plakin, who's a psychiatrist who's been working diligently on this case and was one of the plaintiffs, that there's certainly going to be an appeal. But one would hope that in the meantime, United Behavioral Health will act more responsibly. This judge has called them devious, evasive, immoral. If I were a company and I had been labeled like that in a federal court case, I think I would start behaving in a way that was more helpful for the people I'm supposed to be caring for. What do you think about this case? What is its impact in your mind, and what can we hope for as far as improvements go, do you think?
Sure. Just to recap the case for some that may not have seen it, but basically what the plaintiffs were arguing is that the insurance companies were using, we'll call it inappropriate or erroneous care criteria for various levels of care. So, for example, to determine if a patient should be in residential treatment center, they were using either acute inpatient, which is a higher level of care, or they were making things up that aren't based on how medicine is run in this country. ASAM, which basically is a professional organization which establishes guidelines on care criteria. The argument made in court was that the that the ASAM guidelines should be used, or there should be a uniform guideline across the board for various levels of care. It shouldn't be able to change. This is what the medical community agrees to. And United Healthcare was running afoul of that on a day in, day out basis. And we see it all the time in the work that we do, where they're saying, for example, at residential, well, the patient's not actively suicidal. Well, if they were actively suicidal, God forbid we know what would happen, or they would be in an emergency room. They wouldn't be in a 30-day residential treatment center. So they're using these wrong care criteria. So the hope is that United Behavioral Health, which is the mental health, or Optum is the mental health component of United, Oxford, and all their subsidiaries, is now going to hopefully apply the right care criteria for the right level of care. Certainly in the work that we do, we're going to be calling them out effective today and saying, hey, we're aware of this case, and kind of put them on notice. If I'm Cigna, Aetna, Blue Cross, I'm going to be nervous about this too, because this is not only going to affect United, but they're all doing the same thing as well. So, the hope is that, at least give the families a fair shake. At least use the right care criteria for the right level of care. Don't use, I'm trying to think of something on the medical side. Don't use cholesterol medication to solve a spinal injury. It just doesn't compute. So this is a big case. Myron Bendit was the lead, plaintiff's attorney. He's a brilliant man, and this was a long time coming. And I really think there's going to be ripple effects throughout the industry. Yes, this is still months before a final ruling and actual monetary damages are assessed, and until we're going to know, how this is going to impact the industry as a whole and patients. But this is what we need. This is absolutely a major case. It's something that we've been struggling with, families have been struggling with. So kudos to everybody that was involved, and this is only the beginning to start to break through and get these carriers to do the right thing.
Very good. Yeah, and I mentioned Eric Plakin, who's a psychiatrist I know, and he's also the medical director at Austin Riggs in Massachusetts. But I was able to sit with a group at the Group for the Advancement of Psychiatry, their psychotherapy group, and Miriam Bendit has been involved with them as well. And it was great seeing the psychiatrists mostly who were gathering around, seeing the need for going beyond hospital care and making sure that there are options for residential and other types of care beyond that. So, yes, kudos to that.
Sorry to interrupt. I just wanted to add one more thing, because we touched upon it earlier when we were looking at how many days can you expect to be authorized for residential. One of the findings in the case said just because a patient is doing better in residential is not cause for stepping them down immediately to partial hospitalization. And equating that to the medical side, if you're giving cholesterol meds, once somebody's cholesterol is stabilized, would you then immediately take them off cholesterol medication? The answer is obviously no. It's working. So that also was addressed in the case, which will hopefully prolong the amount of days authorized in treatment.
I hope so. And by the way, any of the viewers that would like to have a full copy of the document that came out on Monday, it's a little over 100 pages, just email us and we're happy to email you a copy of that. A couple of highlights that I see from some of what the judges said is that treatment now will have to address the underlying condition, not just the crises, the symptom crises. Also coordinating care. I mean, this is a big win for those who really believe that mental health care and substance abuse care should be coordinated and not handled separately. And the judge is also calling for, in cases where there's ambiguity, that the practitioner who's really giving the care should be able to err on the side of caution and make sure that the right kind of treatment is available. And I love the language also that says that the treatment should help to prevent deterioration and not just address the immediate crises. And for those who take care of children and adolescents, there's language in the case too that calls for some unique guidelines for improving access to care for them. So it's all good. And again, I would hope that this case will help UBH begin to, and Optum to behave better immediately. But it's going to take a while for all of this to be worked through the courts and probably through an appeal process. but there's hope. While and I know you have another case that you'd like to comment on, Scott, but let me just go through, because questions are coming in. Let me just go over some of them that you might have in mind. One viewer says, shouldn't we just have universal health care where all of this is standard and we have good coverage? Another person, as a program leader who's listening of a residential program, wonders what program leaders can do to help in this process, help families, help gain access. What can they do to help advocate? And also another parent is wondering, okay, how can they transition? They want to transition from a company self-funded policy to Medicare, wondering how that works. That's a pretty specific one. And then another one, the UBH case seems to demonstrate your point that, they were just following the money.
Yep.
And in so doing, I mean, in this class that sued them, I mean, there are cases of people who died because they were not given the care that they needed. I mean, they've got blood on their hands. So I don't know if you want to respond.
Yeah, I could talk to them. I could talk to them all. Medicare for all, without getting too political, I think that's going to be very bad because the government can't even function, to keep our parks open. So I certainly don't want them to, dictate care. And I do work with a lot of, TRICARE providers, and which is based on, the government rules and regs, and it's just it's an absolute disaster. And TRICARE services the veterans and the military, and they just do an absolute horrific job of taking care of people that are serving in the military. So I certainly don't think that's a good way to go. Maybe a public-private combination, but that's going to get a little political, and I just want to stick to how we can get treatment. But I on the face of it, Medicare for all as it stands now is in my opinion, wouldn't work. What can program leaders do to help this? More outcome-based, research. So, following the patient 1 week, 1 year, 1 month, call it what you will, post-treatment, and really documenting and recording. The patient was in treatment for 30 days. This is where they are over a course of time. Our patient was authorized for 15 days. This is where they are. So the more we can actually have documentation with these findings, I think it's going to be very, very powerful with future cases, or to lobby your congressman, or to use organizations like Virgil you're a part of, or Shatterproof, or various other lobbying organizations that are out there to say, hey, here's proof. Here's, a sample size of 50 people who went through 30 days. This is where they are. Here's a sample size of 50 who went through 10 days of a program. This is where they are. And if you're able to demonstrate that difference, it's going to be very, very impactful. So certainly that documentation is needed.
Just pause just a moment there, because I think you hit a very important topic. So program leaders listening, the more that there could be collaborative work that can demonstrate good outcomes, the better it's going to be.
Yes, and bad outcomes if the insurance companies are denying and kicking people out of treatment. Either way. But let's start to really record this in a methodical manner. And you need buy-in from all these program leaders.
Okay.
And then self-funded Medicare, I just was going to touch on that. So self-funded, if you're going to look to switch to Medicare from a self-funded, outside of open enrollment, there has to be a qualifying event. I would actually encourage whoever asked that question to call me offline, because there's a lot of nuances that could go into this.
Okay.
It certainly is possible, but that's going to get very specific to the person who asked that.
Okay. Well, thank you for inviting that call, and as we also near completion, there will be a slide that shows your email address so people can connect with you. Let's move for a moment to the other court case that you were telling me about that appears as though it's really putting a lot of pressure on healthcare providers to become in-network and accept much lower rates than they can afford to do. Can you tell us a bit about how this case is
Sure.
going?
So out of California, again, there's another attorney that is leading a suit against Anthem, the parent company of Blue Cross and Blue Shield of California, whereby the claims being filed with assignment of benefits to the provider were actually being paid to the patient. Where this really has an impact is on those providers treating those with substance abuse issues. So let's say you have a patient who's in a 30-day detox residential program for heroin addiction, and the provider gets authorization, files a claim to have the provider reimbursed. Now Anthem is sending the money that's due to that provider to that patient. So after treatment for heroin addiction, someone's going to get a check for $10,000, $20,000, $30,000. Well, that's putting them certainly at risk, because what do you think a former addict's going to be doing when they just got a check for $30,000? Odds are they're going to go back out and use. And this is also an attempt to get those out-of-network providers to either become in-network or out of business, because you can't stay in business too much, for that long if all your reimbursement is going to the patient and you're having to chase the patient. So this is absolutely an attempt to get these facilities, again, to either become in-network or, more importantly, out of business. And there are people that are dying as a result of this practice.
We're a civilized society, right?
Yeah.
I think the way you measure the health of a civilized society is you look at how it cares for its most vulnerable people. A lot of the people on this call are family members with those vulnerable people, program leaders trying to care for them. I don't know that I wonder how many insurance companies are on this call. I'm not sure. And let's hope that they can go in that direction too. We've got questions coming in, my goodness. Okay, here's one. What can a regular citizen do to help with this movement? Now, I did notice in regards to the court case you were describing, I saw that there was a leader from NAMI chiming in, talking about the importance of this. So I guess NAMI is one place to go if you want, as a citizen, to advocate for some of the legislative solutions that may be needed. What other thoughts might you have, Scott? Where can someone go with, we've got all this pent up energy. They see and feel the injustice and they want to help fix it. What can they do?
Right. I mean, the real thing is lobbying your congressman. And I know a lot of people look at that and say, do they really care? And we don't know. But certainly you can't go a day without turning on the news and hearing about opiate addiction and that crisis or mental health illness. So, I would just say be another voice that can demonstrate how, illness, mental health illness and substance abuse has damaged your family. The more and more they hear of it, the more and more they have to act. And then obviously coupled with going to NAMI and other organizations. But if we're quiet, we're going to get nothing done. So we have to scream and scream it loud.
Scream and scream loud. Okay. I've got a sense that some of the people on this call are perhaps doing that to a certain extent already and may even be doing more after this. There are more questions, I'm afraid, that we're not going to be able to get to fully. I know that we want to be finishing up, I think, in about 2 minutes. We have a caller who's wondering about optimal use of the continuum of care for a child. I'm happy to take a call like that, by the way. We can answer the questions that we don't get to today also on our blog. So the blog for our website under virgilstuckerandassociates.com, the questions that we don't get to today, we'll post there and also try and answer. And also, like you, Scott, we're willing to take calls. And I know that you've helped a lot of families, and I really appreciate that. Seems like you're always available, and you've grown from one person to 42 people who have a heart and a head for this. So I thank you for that.
Shouldn't be needed, which is unfortunate, right?
Right.
I shouldn't be needed, but
Okay. Well, if we're all successful, that might put your business out of operation. But I
That'll
doubt
be
that
all
that's
right.
going to happen anytime soon. Scott, just bless you for what you're doing. What else do you have to add to the sense of hope that we're creating, as well as the energy that people are feeling about wanting to do something? Any
Yeah,
any words
so
you'd
I
like
would
to
just go
conclude
back.
with?
Yeah, I would just go back to what I started this conversation with is, you have to really be that squeaky wheel. Obviously, educated in your policy, know your rights, and don't give up.
Hmm.
And I'll just take an aside for a second, just personally, and we spoke about why I got into this over Christmas. So my son had a massive stroke. He has a lot of medical complications. I've been with United Healthcare for his entire life, and New Year's Eve, I get a call from my son's nursing agency that they're denying my son's nursing care effective the next day, January 1st. So you
Oh,
can imagine, here I am, New Year's at 4 o'clock. I'm with my family, and now my whole life's turned upside down. For 12 years, I was getting nursing coverage. I had to prove medical necessity every 3 months, but now they say no more. Um, and that night and the next day and the weeks thereafter, I spent all my time and energy on fighting. Thank God, knock on wood, it was successful. But this is a nonsense. So you just gotta keep at it. I know it's exhausting. I'm always available to answer any questions and help. And really, it's a full-time job, unfortunately. But if you keep after it, that's the way you'll find success.
so we will keep after it, Scott. I
Great.
thank you so very much for joining us today, for
Thanks for
imparting
having
some
me.
of your wisdom to those who have joined us. And thank you all, by the way, our audience, for joining us today. And reach Scott. You see his email address, SL for Scott Leshin at sjhia.com for SJ Health Insurance Advocates. So give Scott an email if you have further questions, and you're welcome to also email us. You know our addresses, I'm sure. And again, the questions we didn't get to, we'll try and put on our blog. So Scott, thank you very,
Thank
very
you.
much. And have
Thank
a
you.
good rest of the day, you and all of our listeners. Thank you.
All right. Goodbye.
Bye.